Let's go.
I'll shut up now.
Good morning, everyone. Welcome to today's American Community Weekly National Briefing. I'm Sunita Sarabji, health editor at ACOM, and your moderator for today's discussion. Our topic today is, are we now cutting healthcare to the bone? 2026 brings sweeping changes to healthcare access in the US, driven by a mix of new rules, budget law changes, and Medicare and Medicaid reforms. Without enhanced premium tax credits, American consumers who buy healthcare through the Affordable Care Act marketplace could see their monthly premiums jump by at least 70%. Analysts note a $45 billion cut to the Medicare budget next year, amounting to $536 billion over the next decade. H.R. 1, also known as the One Big Beautiful Bill, which passed the House this summer, strips $900 billion from the Medicaid budget over the next 10 years and adds new work requirements, which many current recipients may not be able to meet. As well, the Trump administration has reimposed the public charge rule, adding fear for eligible recipients who may not apply for benefits to which they are entitled. Speakers today will unpack the massive changes in healthcare costs for 2026 and beyond, and offer perspective on creating a more equitable and affordable healthcare structure. We invite reporters to post their questions in the chat, and we'll address as many as possible immediately after each speaker presents. We ask speakers to speak slowly for our simultaneous interpreters in Korean, Mandarin, and Spanish. Jessica, could you please start the live streaming now? So please welcome our three speakers. First, Thomas Bednar, Senior Vice President and Counsel at Healthsperian LLC. Amber Christ, Managing Director for Health Advocacy at Justice in Aging. And Sophia Tripoli, Senior Director for Health Policy at Families USA. And so we begin. Thomas, welcome. Thomas will discuss and will provide an overview of what's at stake for healthcare consumers in 2026. He will also focus on public charge. Welcome, Tom.
Sunita, thank you so much for the invitation. Thank you to the American Community Media and to the broader ethnic press. It's a great honor as an immigrant myself to be able to address all of you, and looking forward to the conversation. So I think the framing that you outlined there, Sunita, in your first few sentences really says it well. I'm going to start by identifying a few themes that I'd like for all of you to keep in mind. And then I'm going to go very specifically to a very specific item, the last item that Sunita mentioned, which is representative of some of those themes, and I'll build on the rest moving forward. I'd say the themes for 2026 that I think all three of us, and more broadly, the American health policy and just the American community at large are looking at are cost increases, access decreases, and from a political perspective, the high probability of gridlock on large-scale changes and reforms in anticipation of a midterm in the middle of this year. So let me address first representative of some of the access decrease issues that is an explicit stated goal of the administration right now. Specifically with respect to public benefit programs and in relevant part the Medicaid program. More broadly, the administration has positioned itself both in the legislature through the Republican Party, but the administration itself through the executive branch is seeking to return Medicaid to its perceived initial definitions, the populations that it perceives to have been the intended recipients of Medicaid. The net effect of that is to try to establish policies that limit access to Medicaid, which is, for those unfamiliar, the primary safety net source of health insurance for low-income Americans and certain other residents. And I say that specifically. And so a representation of this kind of returning or a narrowing is what Sunita mentioned just now, which is the a proposal of changes to what in our parlance is known as the public charge rule. The public charge rule is for lack of a better way, and for the past 7 to 8 years, has been a ping pong change of rules implemented initially in the first Trump administration, which seeks to make changes to the factors that immigration officials can take into account when assessing the validity and approving permanent resident status, what we colloquially still refer to as the green cards, though for any immigrant, it's not green anymore. They used to be, but they're not anymore. And for the longest time, factors related to accessing public benefits like Medicaid were not allowed to be considered in the application process and the assessment of eligibility. In 2019, the Trump administration sought to change that and implemented the first change to the public charge rule that allowed consideration of an applicant immigrant's use of public benefits as a means of potentially disqualifying them for purposes of green card acceptance. That was met with resounding pushback from across the sectors, both the industry as well as the consumer perspectives. I'm sure Sophia and Amber can speak extensively to that. And in relevant part, it was due to the fact that there was a fear of a perceived chilling effect to the access of Medicaid, meaning that even if the changes weren't applicable to you as an immigrant, you were being dissuaded from accessing the benefit because of the uncertainty of whether or not this was going to apply to you. In 2022, the Biden administration walked back any of those changes that the Trump administration initially implemented, and in fact created new regulations that explicitly did not permit the consideration of these factors. So you can see how my ping pong analogy is starting here. Where we are today is very recently, we have a new proposed rule from this Trump administration to go back to what they proposed in the original Trump administration. And thus the second whack at this ping pong ball is back to where we were under the first Trump administration of allowing permission of consideration of these factors. The change, perhaps, and it will be interesting to see the reaction to this, is that in contrast to the concern around the Medicaid chilling effect that was raised in 2019, the context for Medicaid and Medicaid access is far different today, namely because of the changes implemented by the OBBBA, OBA, or HR1. As Sunita rightly outlined, that legislation included significant cuts to the Medicaid program. It, in fact, targeted certain subsets of the immigrant population from eligibility from emergency Medicaid services. And thus, the net effect is that this public charge rule comes in the broader context of a far larger attack on Medicaid than was occurring in 2019. We see no reason that this will not be implemented, but for perhaps legal challenge, but it seems likely that these changes will be put into place. And I want to draw us back again to the themes that I raised, which was cost increase, access decrease, and general political gridlock. This public charge rule is reflective of that middle one of those, an intentional limitation of access to Medicaid benefits from out of this chilling effect, as well as being part of the broader immigration policies that this Trump administration has taken on. Shifting a little bit to that first theme of cost increases, Sunita outlined the possibility, and here I'm going to be talking about the elimination of the advanced premium tax credits, which is probably the topic du jour for most of us in Washington, D.C., focused on healthcare. I say that this is in the theme of cost increases because what's at stake here, as Sunita well outlined, is the massive increase in premiums for those Americans that receive access to health or receive coverage through the individual markets. The individual markets were implemented under the Affordable Care Act, and now we've just accepted that it's part of Obamacare. And to give you a sense of the scale here, 22 million Americans, or roughly 92% of beneficiaries on the individual markets, access APTCs in some fashion. They're provided on a gradient based upon income. But the knock-on effect here is that if these advanced premium tax credits are not reinstated, that number of Americans will lose some or a large portion of the subsidized access to healthcare that they receive. Very briefly, how this works: APTCs are a tax credit that individuals receive, but it's divided by 12 months, and that money, instead of being sent to the individual, is sent to the healthcare insurers as a means of lowering their premium cost. That's how they operate. If that subsidy is eliminated, those costs have to necessarily increase because the underlying cost of healthcare hasn't changed. And therefore, the net effect is that the end recipient, the end beneficiary, the end consumer sees a significant cost increase. This is a heavily politicized battle. It is, in fact, right now, arguably the most politicized component of what is facing us today on the Hill, which could be another government shutdown at the end of January, though we're none of us are hoping that that's the case. But to answer indirectly one of the questions that's in the chat, yes, healthcare is political, and the APTCs are a direct example of that politicization. I want to be mindful of time, Sunita, so I'm going to run through just a few other themes, and please keep me honest so that we have enough, so we stay on schedule. I've talked about two very specific examples. I want to talk a little bit about what else is coming down the road in 2026, and I expect likely Amber and Sophia will pick up some of these threads because they're on all of our radars. We mentioned already HR 1. 2026 will be the first year where many of those changes that weren't immediately put in place do come into effect. In relevant part, towards the end of 2026, Medicaid access to Medicaid will be further constricted for some immigrant populations. That I think the implementation date is October of 2026. More broadly, there's going to be further fiscal pressures put on states that expanded Medicaid for reasons at the beginning of 2026. What does that mean? The net effect to the consumer is states, and we have already seen this, have massive budget shortfalls in a very short period of time that requires them to cut their Medicaid programs or find the funding in other fashions. That places significant pressure on individual states to carry the burden of the legislation under HR 1. And therefore, again, that theme of access decrease, because the choice by the states will be limited in terms of what they can do to actually make up for that budget shortfall, if that makes sense. A couple other things that may not be as broadly discussed but are very important in our smaller world. 2026 is actually the first year where Medicare will be officially negotiating drug pricing. Drug pricing remains one of the hard to characterize topics of conversation in health policy. There have been some meaningful reforms, not just under the Trump administration, but certainly under the Biden administration. Remember that drug price negotiation was a consequence of the IRA, Inflation Reduction Act under the Biden administration, and has not yet been repealed or meaningfully eliminated under the Trump administration. In fact, implementation has carried on largely unaffected to this administration. Moreover, President Trump has made not just overtures, but some very concrete policy steps towards changes in the pricing for the payment of drugs, particularly in the government-sponsored healthcare side of things of Medicare and Medicaid. The merits of those changes, I think, can be hotly debated, but there's a stark contrast between what the first Trump administration did, which was mostly talk about such changes, and what they've sought to do here, which is seek to implement many such changes. And I think 2026 will be where we start to see some of the net effects for consumers. And I think the final thing I would note, and I'll then be quiet, is I think that anybody paying attention to the political position with respect to the healthcare of this administration knows what the MAHA agenda is from HHS Secretary Kennedy. And this is a broader theme that I didn't explicitly state, which is that although the Republicans are not a monolith with respect to their approach to healthcare. They have very important subcomponents, and one of those subcomponents is the MAHA agenda represented by Secretary Kennedy, which is an agenda primarily focused on nutrition, lifestyle changes, and dietary components as fundamentally driving healthcare costs. This has most concretely been seen with changes to vaccine policies and very contested changes that Secretary Kennedy has implemented in terms of access to and the policies related to the coverage of the availability of the research for new and current vaccines. But it will also in 2026 continue to extend into other elements, such as potentially more explicit consideration of the access of or payment for nutrition, diet, lifestyle, and the incorporation of those things into Medicare and Medicaid. That needs to be reconciled with what I said at the outset, which was this administration's desire to bring Medicaid and government spending in line with what is perceived to be a more narrower confine. So that kind of reconciliation process is something I'm particularly interested in and will certainly have direct impacts on consumers. I've discussed a lot of things, and I'm sure I've left a lot undiscussed, but for purposes of time, let me stop there and see what questions we may have.
Well, there are a number of questions for you, Thomas. I would like to start out with my own. How many people do you predict will drop off of healthcare permanently because of the outlines that you just suggested? And will costs increase overall for all consumers as a result of fewer people being in the system?
I'm not going to commit myself to a concrete number. What I
Fair.
will say is over time, it is if the policies remain unchanged, it is likely to be in the millions, many millions of individuals, especially if access to ACA coverage continues to be so unaffordable. The cost to the increase or the increase of the uninsured population is likely to. I should note, we are at one of the lowest points of the uninsured population in the history of the United States, and that has the possibility of fundamentally rebounding. By that, I mean significantly increasing in a very short period of time because of the elimination of the APTCs. And so for that reason, I would say over the course of this year and perhaps several others following, millions. To the latter point, in the health policy circles, we often treat healthcare costs as the analogy to the balloon. And if you eliminate large portions of the population from that balloon and you leave only the more costly, the sickest, who are more likely to have access to coverage through Medicaid, certainly, you by definition increase the overarching pressure on the payers, whether that's government-sponsored payers, whether that's commercial payers, et cetera. The elimination of the APTCs is perhaps the most direct way to massively increase costs to the consumers and to healthcare, but there's also the indirect net increase that is at risk here through the significant increase in the uninsured population.
Pamela Anchung, will you please ask your question? Pamela is from Immigrant Magazine.
Yes, Sunita, thank you so much. Now, immigrant families, as we know, are typically afraid to seek care because, of course, there's a public charge and sometimes the mixed status. Are there any protections in place for immigrants who are eligible but terrified to apply? Because we're really living in unprecedented times.
Yeah, so I am unfortunately an attorney that used to manage these things, but here I am not commenting as an attorney that is advocating on behalf of individuals. The technical answer is yes. There still remain protected classes of immigrants that are lawfully eligible for things like Medicaid coverage, as well as potentially access to advanced premium tax credits. The number of people and those populations have been intentionally winnowed by the changes in HR 1 as well as other policies that remain to be implemented now. The real distinction that's relevant here is that it remains true that there are absolutely lawful means of access to coverage via Medicaid and other services for immigrants. And this chilling effect likely eliminates or decreases the willingness of many of those immigrants to access those things, right? So the short version of this is that fundamentally the access to healthcare for the large portion of those that were previously eligible for healthcare through government-sponsored insurance hasn't fundamentally changed. What has changed, and there are exceptions to that, what has changed is the posture of this administration and the pressure and, of course, the scrutiny that is being placed on the immigrant population relative to what was under the last Trump administration, or excuse me, under the last administration. So hopefully that answers your question. And
Yeah.
I would say, I would direct folks to your folks to entities such as represented by Sophia and Amber here, as well as national immigrant law and consumer advocacy organizations.
Henrietta Burrows of East Palo Alto today has the next question. Henrietta, please ask your question.
Thanks so much, Sunita. My question is somewhat aligned with Pamela's in talking about the groups who were eliminated from eligibility. So could you go a little bit more into detail in terms of which groups were they eliminated along racial lines also, and which groups were not eliminated?
Sure. So let me clarify. The public charge rule hasn't eliminated access. What you're likely referring to are the changes that were included in HR 1. There was a narrowing of Medicaid eligibility, specific emergency Medicaid eligibility for a subset of Medicaid enrollees. And off the top of my head, and I hope my colleagues will keep me honest here, asylees, certain categories of children, those seeking other sanctuary, and I'm forgetting a certain category. But it is a certain subset of the immigrant population. It did not change the underlying structure of what's known as the 5-year rule, which has been in place for decades. That is the general ban of access to public benefits 5 years post-immigration, even for lawfully permanent resident aliens. So it wasn't a large portion of the immigrant community in HR 1 that was categorically excluded. Nevertheless, those populations that are disproportionately vulnerable and tend to have high needs for medical services.
Thomas, thank you so much. There are so many questions for you in the chat. Could you please answer them there in the interest of time?
Sure.
Thank you again. We will move on to Amber Crisp from Justice in Aging, who discussed the impact of these cuts to the older population and also the concept of dual eligibility. Welcome, Amber.
Thanks, Sunita, and thank you all for having me here today. I just put an answer to that question on immigration into the chat, by the way, so people have it readily available. So for those of you who do not know Justice in Aging, we're a national legal organization, and we're working to end senior poverty by making sure older adults with limited income and resources can get the healthcare and economic security they need. And I really wanted to start off today, and my big focus is going to be on the Budget Reconciliation Act, or HR 1, or the One Big Beautiful Bill Act, whatever you want to call it. We refer to it as HR 1, so that's what I'm going to call it here. And I really wanted to center older adults in the big picture of HR 1, because HR 1 at a fundamental level is significantly redistributing household resources. So for those with the lowest incomes, they're going to see their household resources decrease the most because of HR 1. They're going to see a decrease of about 3% or $1,200 a year from their households. Meanwhile, households with the highest incomes will see their household resources increase by almost 3% or $13,600 a year. And the losses for those who have the lowest income is really because of cuts or in-kind transfers, but from cuts from Medicaid and the SNAP program. And the increase in household resources for those who have the highest income is a result of having to pay less in taxes. So if I put this like in the clearest terms, HR 1 really paid for tax cuts for the wealthiest people in this country by cutting public programs for the people with the lowest incomes. And that context is really important in terms of older adults because most older adults live on limited resources. There's sort of a narrative that older adults have a lot of income and wealth, and it's just not the case. The median income for older adults is around $30,000. 70% of older adults earn less than $50,000. And if you look at household income, the average household income of those 65 and over is about $57,000. And it's the lowest of any age group. And nationally, 15% of older adults are living in poverty. And this year, according to the census data, older adults were the only one to experience an increase in poverty rates. And that increase has been happening every single year since 2020. And why that's important for this conversation is because HR 1 cuts the very programs that older adults living in poverty rely on. So that's cuts to Medicare, it's cuts to Medicaid, and it failed to extend the enhanced premium tax credits under the Affordable Care Act, which we were just talking about. It also makes unprecedented cuts to SNAP, the food assistance program. And I want to note a theme here, and this has been obviously coming up, is that HR 1 specifically targeted eligibility for immigrants, and that included immigrants with lawful status, refugees, asylees, and immigrants with temporary protected status. And as Thomas said, those are particularly vulnerable groups who are losing their healthcare insurance because of HR 1. So if I turn to like what those HR 1 cuts mean for older adults, I think it's important to kind of talk a little bit about those programs, Medicare, Medicaid, and ACA, and how they work for older adults. And I won't go into huge detail here for the sake of time. We could spend a lot of time talking about Medicare and Medicaid, but I'll just note that Medicare is the primary healthcare insurance program for 70 million older adults over age 65 and many younger people under 65 with disabilities. It is the federal program. You become eligible based on paying Medicare taxes for a certain period of time. And many people believe that if you have Medicare, everything's covered. But Medicare has huge gaps in coverage, and Medicare is really expensive. And it's Medicaid that fills in those gaps for 12.5 million older adults and people with disabilities who have low income and resources who are dually enrolled in both Medicare and Medicaid. And I'll just point out that the biggest gap in Medicare coverage is long-term care. It's Medicaid, not Medicare, that is the primary payer of long-term care in this country. It pays for over 60% of all nursing facility care, and it is the primary payer of at-home care known as Medicaid home and community-based services. Medicaid also fills in other gaps that traditional Medicare does not cover, like dental, vision, hearing. And I'm saying all this because it's important in the context of what it means when you cut Medicaid for older adults. It's really impacting a lot of Medicare enrollees as well. Medicaid also makes Medicare more affordable. Medicare is very costly. There are high monthly premiums. For every doctor or specialist visit, you have to pay 20% out of pocket in co-insurance. Not to mention there's co-pays and deductibles. Medicaid actually pays those costs for low-income older adults and people with disabilities. So without Medicaid's financial assistance, older adults and people with disabilities could not afford Medicare. Medicare would become an unusable benefit. In fact, 30% of all Medicaid spending supports Medicare enrollees. Medicaid also plays an essential role for aging adults ages 50 to 64 and people with disabilities, those with chronic conditions, caregivers who are insured by Medicaid through Medicaid expansion. Medicaid expansion is the expansion of Medicaid under the Affordable Care Act to adults with low incomes. More than 5 million aging adults ages 50 to 64 are enrolled in Medicaid through expansion. and over 4 million family caregivers are enrolled in Medicaid expansion for their own health care. The Affordable Care Act and the marketplace coverage also plays a real role for older adults, people who retire early or might take part-time work because they're providing caregiving, for example, or they're getting ready to retire, or they have chronic illness and can't work as much, enroll through the marketplace and through the affordable and received enhanced premium tax credits. In fact, 51% of people receiving enhanced premium tax credits are individuals ages 50 to 64. So the cuts that we're talking about today to Medicare, Medicaid, and the Affordable Care Act have significant ramifications for older adults. If we start with Medicare, this goes to a conversation we were just having. H.R. 1 is actually ending eligibility for Medicare for millions of lawfully present immigrants, including refugees, asylees, and the people with temporary protected status. And this includes people who have paid into Medicare taxes for years, and they're no longer going to have access into the coverage they paid into. In fact, their coverage is going to be terminated if they're already enrolled in Medicare. And this is unprecedented. And no time in history that we are aware of has have people lost who have had eligibility for Medicare, lost eligibility for Medicare. And as a result of this, they'll become uninsured because they will not be able to afford marketplace coverage because they won't be eligible for enhanced premium tax credits because the same population can't get those. And they won't be able to enroll in Medicaid because the same population also cannot enroll in Medicaid. So we're leaving millions of people uninsured. And then, of course, we have the Medicaid cuts. There's nearly, like Sunita said at the top, over almost 1 trillion cuts to Medicaid, either through direct cuts to states and federal funding, or from eligibility changes that will mean fewer people will be enrolled in Medicaid. And this is going to have such a significant impact on older adults, but it's one that I think during the whole process of H.R. 1 being passed that just got glossed over by lawmakers saying that's not going to happen. And that's that direct federal funding to states. So states are going to lose billions of dollars in federal funding for Medicaid to operate their Medicaid programs. And states are going to have to fill that budget hole. And there are really only so many ways to fill a hole of that size. You're going to have to cut provider rates, you're going to have to cut eligibility or cut benefits, and probably all three, right? Because these are significant holes in budgets. And the big deal for that for older adults in particular, focusing there, is that much of what older adults rely on in Medicaid are optional for states to pay under federal law. So dental, vision, and hearing, like I said, aren't covered by Medicare. So Medicaid is who's paying for that, all optional under federal law. That means they are the first to be targeted for cuts when states are trying to fill a budget hole. The big costly optional benefit are Medicaid home and community-based services. These are those services that help people remain at home and connected to their communities rather than having to go into nursing facilities. Home and community-based services account for 51% of optional spending in Medicaid. So if you're a state, you're going to turn to that. And in fact, during the Great Recession, every single state cut HCBS in some way. They cut provider rates, they cut hours, or they cut eligibility. And we anticipate that now. And in fact, we're already seeing that. Just most recently, Colorado's governor is proposed cutting HCBS provider rates and hours of personal care to older adults and disabled people. Of course, those cuts aren't inevitable. We could get rid of H.R. 1, which would be ideal. But the other thing is states could raise revenue. But that's just a really hard lift for states to raise taxes. So if you have a budget hole this magnitude, we're really left in a tough spot with very few options. I'll note that arguably the most fundamental change made by H.R. 1 is adding work requirements, or what are community engagement requirements, to Medicaid. This does not impact people on Medicare. So it's not going to should not impact older adults who are enrolled in Medicare or disabled people enrolled in Medicare. What it's targeting is the Medicaid expansion population. So those individuals who are aged 50 to 64, who have a disability or a chronic condition or a caregiver, all of them will now have to prove that they are working or that they meet some exemption from this requirement to maintain their healthcare coverage. And the Congressional Budget Office estimates that 5 million across the country are going to lose access to this coverage because of the requirements. Not because they aren't working, not because they don't meet that exemption, because of the red tape of having to prove those things means that they're going to lose that coverage. So we have those big things in Medicaid. And lastly, if I just quickly turn to the Affordable Care Act marketplace, if those enhanced premium tax credits are not extended, I noted that older adults age 50 to 64 represent 51% of those getting enhanced premium tax credits. So if those don't get extended, it means that those individuals are going to see their premiums increase, probably to unaffordable rates. People who have previously not had premiums at all are going to see a premium for the first time, and these are people with extremely low income. And as Thomas was talking about, when you have people who have, these are people who are more likely to have chronic healthcare conditions and need coverage. So they're going to be sicker. They don't have many other options. The healthier people will drop out of coverage, making it even more expensive. And we turn into this kind of death spiral, leaving people without any coverage. So we go from that rebound that Thomas was talking about, that we're at the highest rate of uninsured right now, and we're in a position right now where we're going to see that completely rebound and millions of people losing coverage. I'll stop there for the sake of time and open it up for questions.
There are a number of questions for you, Amber, but I wanted to start out with one of my own. Do you see a significant drop in funding for caregiving services and things like transportation for seniors to go, where do you see these cuts happening in real programs and services?
Yeah, so if we talk about Medicaid, the home and community-based services bucket, all of that is optional. So if you're someone like maybe an adult day health center that you're going there and you get transportation to go to and from there, that adult day health center services might get cut. So transportation of those services might get cut. That's like within the Medicaid bucket. Transportation in Medicaid to medical appointments is a required benefit. So less worried about that. But I didn't touch on this. The other thing that's at the same time happening with Medicare and Medicaid and the Affordable Care Act are kind of pillars of healthcare coverage. All of that is happening over here. We're also seeing all of these cuts to federal funding to things like Older American Act funded programs. These are the programs that provide some of these wraparound services, transportation, respite care for caregivers. That's also simultaneously being cut, and not through necessarily a budget bill, but through appropriations process, or just the Administration for Community Living not providing that funding. So we're seeing it like all of these this shift, right, from federal funding to states. And I would say that this is a theme here, is that the federal government is stopping funding, federal funding for hundreds and hundreds of types of programs, and they're shifting those costs to the states and then ultimately to the people, because there is no way for the states to fill those holes, right? And so ultimately, it is the people who will lose their health insurance coverage. It is the people who will lose those services. And that is like an overarching theme of what we're seeing happening right now.
Yeah. Araceli Martinez has from La Opinion has a question. Araceli, could you please ask your question?
Yes, Sunita, thank you for the opportunity. Can you listen to me?
Yes.
Thank you. I was wondering, trying to be optimistic, if Democrats regain control of Congress next year. I was asking to myself if these changes to the health coverage could be reversed, and if so, how soon before more dramatic consequences occur? Thank you.
Yeah, that's a great question. So I think that I think the midterms is a pivotal point in terms of thinking about like where we could have policy change happen. And what, regardless, like we should be thinking, we're a 501(c)(3), so nonpartisan, but thinking about like what's happening and what policy change we might be driving towards. And I think that that's exactly what we would be arguing. There are already bills in Congress to rescind the healthcare provisions or to repeal the healthcare provisions in HR 1. So I think that those are opportunities. I think it's really important for media to be telling the stories of what these cuts now, like what's happening now in people's lives, but also what would happen, like what's going to happen. I think that that's a real challenge though, because what HR1 does is it does delay implementation of a lot of these cuts. And I can't tell you each of those timelines right now because they're all different, which also is complicated. But I think that that's a complicating factor is that some of these cuts in theory are in practice aren't going into effect until 27 or 2028. Nonetheless, states are preparing now. And that's what I was talking about, like in Colorado. Colorado is already experiencing a budget shortfall. And in fact, KFF just put out its recent survey of states, and most states are anticipating Medicaid budget shortfalls this year. And that's not even taking into consideration that the cuts that are coming down the pike. So they're already doing things to pivot themselves to prepare for the cuts that are coming down. So people are already starting to feel that in their lives. And providers of healthcare services are already starting to experience that and their reimbursement rates. So I think it's important to tell those stories now.
There are a number of questions about what people can do if they can no longer afford their health care and where do they next turn. So broadly speaking, Minzy Zhu asked about Asian American communities. There are other communities that have expressed similar concerns. Could you address that, Amber? Where will people turn in the absence of subsidized care?
Yeah, emergency rooms, right? That's what's going to happen. We're going to see a lot more emergency room use. We're going to see higher rates of mortality because people aren't going to get the care that they need when they need it. This has huge, you cannot cut $1 trillion out of the healthcare system and not have ramifications across the entire society. We're just going to see just a domino effect of consequences for our entire population. I don't think anybody is immune from this.
We're going
I'm
to take
sorry to be the
one.
bearer of bad news here. I
Yeah.
feel so terrible.
We're going to take one final question from Orhan Akurt before we move on to Sophia. Orhan, could you please ask your question and identify your news organization?
Yes, Zaman America. So my question is about the Democratic leaders. So why the Democratic leaders agree to health care cuts, given that expanded access is usually to a core part of their platform. So why they support it? I mean,
Yeah. And I think there are two things to think about here. HR1 was passed on a purely partisan basis. So there were no Democrats who voted for HR1. The the government reopening and the continuing resolution that and the core of that healthcare debate was the enhanced premium tax credits, and maybe Sophia will get into this a little bit more. That did include Democratic votes, and I can't speak to why their personal preferences were, but there was a lot of complicated dynamics in the government shutdown, and a lot of harm occurring to individual people during that, and lots of people during the shutdown. So I think that that was just complicated by the shutdown itself, versus just purely voting on a healthcare vote. Yeah, and maybe Sophia will add to that.
Thank you, Amber. There are, again, a number of questions for you in the chat. If you could please answer them there in the interest of time, that would be great. We move on to Sophia Tripoli of Families USA, who offers her perspective on how to reform healthcare to make it more affordable and, importantly, more accessible for immigrant communities and for low-income communities at large. Welcome, Sophia.
Thank you very much for having me, and thank you to American Community Media for inviting me to be here today. I'm Sophia Tripoli, Senior Director of Health Policy at Families USA, a longtime national healthcare consumer advocate. I'm especially grateful to speak with the media audience because what you focus on and how you cover it shapes the national, state, and local conversations. And right now, those conversations are urgently needed. We are at a turning point on one of the biggest kitchen table issues in American life, the cost of healthcare. Most people feel this in a very personal way when their premiums go up, when they get a surprise bill, or when they're forced to choose between medical care and groceries. And yet, even though the experience is universal, the reasons behind rising costs often feel complicated and hidden. So I want to start by this. The number one driver of unaffordable healthcare in America is prices, not overuse, not bad decisions. It's prices. And those prices are being pushed higher by two structural forces that have little to do with the health of the American people. It's corporate consolidation and payment incentives that reward volume over value. In almost every corner of the healthcare system, hospitals, physician practices, drug companies, insurance plans have all become increasingly consolidated over the past several decades. Fewer companies now control more of the market. And when companies get bigger, they get more power to raise prices. It's that simple. Hospitals merge or acquire physician practices and then demand higher rates from insurers. Drug companies maintain patent thickets to block cheaper generics from coming to the market. Insurers consolidate and narrow provider networks. And consumers don't get better care. Instead, we get higher premiums, higher deductibles, and confusing bills that bear no relationship to the cost of providing care. At the
Sophia,
same
I'm sorry
time,
to interrupt, but an interpreter has asked you to slow down a little bit.
of course,
Thank you.
absolutely, my apologies. At the same time, we still operate under a fee-for-service payment system that pays for every test and procedure, regardless of whether it improves someone's health. That means the system rewards doing more, not doing better. It rewards expansion, not efficiency. And it certainly doesn't reward prevention or the financial security of families. Together, consolidation and misaligned incentives create a business model where success is defined by getting bigger, gaining leverage, and charging higher prices, not by delivering better outcomes. And we see the consequences of this every day. Higher premiums and out-of-pocket costs, workers whose wages are stagnant because employers' dollars that could go to raises are instead eaten up by healthcare. Reduced access to services, especially in rural communities and communities of color, hospital closures, and worsening outcomes in a country that already spends far more than its peer nations. And while everyone feels the strain, the impacts are not evenly distributed. Low-income families, rural communities, and communities of color bear the harshest consequences: higher medical debt, fewer providers, and worse health outcomes. The design of the system deepens inequities that have existed for generations. This year, the threats to healthcare and health coverage from Congress and the Trump administration have been constant. H.R. 1, the Republican tax cuts, included $900 billion in Medicaid cuts, the biggest rollback in the program's history. The administration's so-called marketplace integrity rule undermines access to affordable healthcare through the Affordable Care Act and threatens the enormous coverage gains that we've made over the last decade. And as we've noted, Congress has so far failed to extend the enhanced premium tax credits, which help to keep insurance affordable for millions. If those tax credits expire, millions of families will see their premiums double or even triple next year. We are layering short-sighted policy solutions on top of a system that was already buckling. Our country is experiencing a healthcare affordability crisis, and only Congress has the power to advance bipartisan solutions to fix it. Families USA is not alone in this belief. American voters overwhelmingly agree. Earlier this fall, we released a poll showing that 91% of voters across party lines say it's important for Congress and the president to take action to lower healthcare costs. Healthcare affordability is a top concern across demographic groups: 47% of women, 49% of seniors, 47% of Latino voters, and 45% of small town rural voters list healthcare costs as their number one priority. Voters aren't just frustrated, they're fed up. They don't just dislike the system, they feel mistreated by it. And they strongly support bold solutions that hold corporate health systems accountable for charging excessive prices. This gives us a crucial opportunity to reshape the national debate on healthcare. Earlier this week, we released a new analysis of next year's health insurance premium rate filings. On average, premiums are expected to be at least 25% higher in 2026 than they were in 2025. And that's before factoring in the loss of the enhanced premium tax credits. Without those credits, consumers could face increases over 100% in some places. Insurers themselves have identified the top drivers of rising premiums: high hospital and provider prices driven by consolidation, rising prescription drug costs, and the expectation of a smaller and sicker risk pool without the tax credits. This makes one thing very clear. Simply extending the tax credits, though absolutely essential, is not enough. We need systemic changes that address the root causes of high prices. Families USA believes that healthcare affordability is not just a kitchen table issue, it is the kitchen table issue heading into 2026. And we have a clear policy agenda for what must happen next. Congress must take immediate action to stop corporate health systems from charging Medicare more for the same procedure simply because it was done in a hospital rather than a doctor's office. Congress must require all hospitals and health plans to actually disclose the price of healthcare services in dollars and cents so that we can actually know how much a procedure costs before we go get care. Congress needs to close legal loopholes that allow drug companies to raise prices through patent abuses. They need to restrict predatory billing practices that inflate healthcare costs for families. They need to prohibit Medicare Advantage plans from exaggerating patients' health risks to get higher payments for Medicare. And we need to modernize how we pay for care so that providers are rewarded for keeping people healthy, not just for the number of services or procedures that they perform. This is an agenda that lowers costs for consumers, for employers, for insurers, and for public programs like Medicare and Medicaid. And that matters for the long-term fight on healthcare because to push for coverage expansions and universal coverage in this political climate requires a bold and progressive agenda to curb the healthcare affordability crisis and contain rising healthcare costs. Coverage and affordability are directly linked. When costs keep climbing, coverage becomes harder to sustain, harder to expand, and harder to protect. Winning on affordability builds the runway for the next generation of reforms, the ones that actually guarantee every person in this country the healthcare they deserve at a price they can afford. And Families USA is ready for that fight. In 2026, we will be urging Congress, as we have for the last several years, but building on that momentum to take bold action to finally address healthcare affordability in a meaningful way for the American people. Thank you for having me, and I'm very happy to take any questions.
Yeah, Sophia, we have a number of questions for you as well. But I wanted to start out with one of my own. People with healthcare often deny themselves the services that they need because of the impact of deductibles. Could you address that issue, the high cost of deductibles in terms of whether somebody gets a coverage or not?
Absolutely. I think we've seen costs, high deductibles, an increasing prevalence of high deductible plans, rising premiums, more out-of-pocket costs for consumers across the country over the last decades. And what that means for many folks is that exactly that. They have to delay care, avoid needed care. And of course, when you delay or avoid needed care, you are not only paying your premiums and your deductibles and your copays, but you actually pay the price when you, in your health, when you delay that care. So it is a big issue. And the other thing I will say too is that what many folks don't always understand is when your employer is, with healthcare costs going up so much, employers are absorbing a lot of that rising costs. And in doing so, it means that wages, your take-home pay and compensation, total compensation and your benefits package is weakened, is less. And in fact, it's the major reason why we've seen wages growing at a very stagnant rate over the last several decades across the country. And so for consumers, you're exposed to more and more out-of-pocket costs, which of course, in this particular climate, is very, very challenging, putting a lot of folks in a difficult position of, do I pay for rent? Do I take my kid to go see the doctor? Or do I put food on the table to feed my family?
Thank you. Irene Diaz-Bazan has the first question. Irene, could you identify your news organization as you ask your question?
Yes, my name is Irene Diaz-Bazan with Prensa Atlanta Global. So my question is, and thank you, Sophia, for this huge information. People is concerned about this issue with a sharp rise in health insurance costs. What would be the immediate consequences for migrants who are trying to support their families, many of whom are also dealing with pre-existing medical conditions? Existing.
Absolutely. Thank you for that question. I think the protections that folks have against being denied care based on pre-existing conditions is one of the most important protections that we got in the passage of the Affordable Care Act. And so it's extremely important. I think to your question about there are all kinds of ways right now in which immigrant communities are under attack in terms of healthcare, as we've heard already this morning or this afternoon, excuse me. There are a number of provisions that were passed in the HR1 bill, the One Big Beautiful Bill Act, OBA, that restrict access for immigrant families in different way to get Medicare and Medicaid coverage and Affordable Care Act coverage. And so I think, how that sort of unfolds is going to be very challenging, I think, for folks who are still eligible for premium tax credits, even though we don't know how that's going to shape up, should still be trying to shop. Right now is open enrollment. People should be trying to get insurance, go through the process if you can, and get services if you can, and make sure you're looking to see how much services cost. Unfortunately, we're in a very challenging holding pattern right now.
Thank you, Sophia. Nestor Fantini has the last question for today. Nestor, please ask your question and identify your news organization.
Yes, Fantini, Hispanic LA. My question, considering that we spend more than any other country in the industrialized world and yet achieve some of the worst outcomes, and of course in our very, very costly healthcare system, and acknowledging the political context in which we are. Do you think that a single payer system remains the best option for the US?
That's a great question. I think for Families USA, I think we absolutely believe in getting to a universal system of coverage. There are many different pathways to get there. But in all of those pathways, we have to address costs. We have to address prices. The more people that come into the system, the more expensive the system costs. And so unless we are able to effectively hold, in this case, corporate health systems who have taken on lots of market power and are able to increase prices, it is the biggest driver, one of the biggest drivers of why healthcare costs so much in this country. Unless we're able to curb those prices and address the market concentration, whether it's a single payer system or some other universal system of coverage, costs will continue to be an issue. And so I think we are growing into a place where more and more costs and coverage are inextricably linked. And to get to the coverage expansions in this climate, we have to have meaningful cost containment strategies and direct relief for consumers. And so that gives a lot of opportunity, I think, in 2026, a major election year, for both parties to come to the table with their ideas that align with where their voters and their constituents are. And voters and constituents want bold reform. They're ready for big changes that make the healthcare system work better, that make the healthcare system more affordable, and make sure that people can get the coverage and the access they need to keep themselves and their families healthy.
Thank you.
Sophia, thank you so much for your remarks. We go next to a 30-second soundbite from each speaker. Let's start with Thomas.
Great. Thank you so much, Sunita, and thanks again to everybody. 2026 is going to be a massively impactful year in the context of health policy and its impact on consumers. Again, to repeat the main themes that we're anticipating: an increase in costs across the board, a decrease in access to healthcare across many of the insurance sectors, and continued gridlock on a political basis that likely precludes meaningful, large-scale healthcare reform from the federal level.
Thank you for joining us today. We go to Amber next.
Thanks again for having me. I think while the policy details around all of this are super complex, if we turn to just the impact on the health and well-being of older adults and every person in this country, it's pretty straightforward. These are some of the largest cuts in history at a time, in particular to older adults, when our aging population is growing and more seniors are aging into poverty. And as a country, we're already underfunding long-term care. And many older adults and their families are struggling to keep the care they need today. These cuts undo decades of progress and will drive more older adults and their families into poverty and crisis. So we really do need to use the power of storytelling and the power of media and the power of transparency to make 2026 to bring meaningful change and investments in these programs and in people.
Thank you, Amber. Sophia, last word.
The healthcare system is going through a rapid change, all of which is exacerbating an existing healthcare costs and affordability crisis in this country. There has never been a better time for lawmakers on both sides of the aisle to put down politics and to come to the table to solve the greatest issues for their constituents and for the people living in this country. And that is addressing healthcare affordability and bringing down the cost of living, including healthcare for the American people. There's a bold reform agenda of a bold reforms that Families USA has put forth to address the underlying drivers of why healthcare costs keep going up every single year, many of which are bipartisan, have been in the past. And we call on Congress to come to the table to find pathways to move those policies forward and to get them enacted for the American people.
Speakers, thank you so much to each of you for joining us today. Your remarks were hugely useful. And reporters, thank you for joining us. We will not have a briefing next Friday in view of the Thanksgiving holiday, but we'll see you on December 5th. Thanks again.